According to Professor Marshall in his forthcoming publication on place names in Barbados, Isolation Road is a residential district located in Belle Plaine, St. Andrew. Under this vestry system that continued to control aspects of public health in Barbados in the early 20th century, the area was a portion of glebe land, that's land that was controlled by the St. Andrew's Anglican Church, the nearby St. Andrew's Anglican Church. By late 1920, the site became the location for an isolation hospital. There were similar developments across the island, with vestries trying to control raging epidemics of contagious diseases such as typhoid fever, dysentery, and influenza throughout the 1910s and early 1920s. Cases of infectious disease overwhelmed the limited health services offered at the time, so parochial medical officers embarked on the establishment of isolation facilities to contain epidemic disease. It's not clear how these sites continued to be used, or if they were used at all, or if they indeed provided effective medical treatment or care. In fact, demographic evidence suggests the opposite, as this level of intervention did not do as much to decrease infection rates as improvements in sanitary measures, access to clean water, better nutrition, and affordable health care. All elements of primary health approaches that were not fully adopted until the mid-1950s. There are a number of isolation sites around the island which continue to be used even as the memory of contagion fades on the landscape. Fast forward to almost 100 years later, last year Barbadian communities erupted in social media protests about the refurbishment of an existing health facility at Enmore in St. Michael. This was the site for the placement of an isolation clinic for contagious diseases, like Ebola. Fearful of the proximity of this facility near to a private school, some members of the community expressed their concern over the selection of the space, which they thought was done with little or no consultation with the local community. Of course, the issue was a microcosm of the larger international discourse of the isolation of the virulent and fatal epidemic, which demonstrated global failures in the human-centered management of disease in Africa, which exclusively branded Ebola as an African disease, resulting in the undesired public health consequence of isolating an entire continent and its people, regardless of geographic proximity to areas affected by disease. And any frontline public health professional will tell you that stigma is the worst way to treat disease. Microscopically, the not in my backyard syndrome in Barbados signaled the state's desire to be proactive regarding an international public health threat, while also, perhaps, unintentionally alienating the public it was trying to protect. Meanwhile, the more immediate but silenced concern for the wider population in Barbados was the unchecked epidemic of chikungunya. This is Makonde for bend up, or as you feel bent up after contracting chikungunya, and the most popular song I think at Crop Over last year was Porgy and Murda's Bend Up, but that had nothing to do with chikungunya. This placed a tremendous burden on an already strained and under-resourced health system and an immeasurable cost for the country's economic productivity and people's health. Community organization around this health issue was noticeably absent, and so was an energetic government response. The more things change, it seems. Spaces like Enmore or the Lazaretto or Blackman Slave Hospital or various cholera burial grounds have become historically synonymous with isolation and even desolation, as places where the afflicted were separated from the rest of productive society and away from the gaze of colonial officials. Interestingly, Enmore was also used as a site for the punishment and execution of at least one of the 1816 slave rebellion agitators, Joseph Pitt Franklin, where he and others were isolated for their treachery and failure to submit to colonial authority. More than a century later, it became the site of the island's first health center and laboratory, and after independence, it became the first polyclinic in the island. It's not the first, the second polyclinic in the island. Only now to return to an association of return to an association of community contestation over the direction of public health policy. We come full circle just in this one space. Barbados' health history summed up in a tale of imprisonment and execution of rebels desiring freedom to the post-independence period, where the promise of modern healthcare to divisive debate over the place of community in healthcare. And now to the stalled pace of 21st century health policy in the island. It leaves us with the question, 200 years later, have we really fulfilled the hopes and desires of our ancestors for equality and meaningful emancipation, especially in the area of health? If we look at how some similar medical spaces have been utilized as we exploit our colonial inheritance, we have not shifted from those historic meanings of contagion, isolation, desolation, and the removal of public health issues from the gaze of local officials. In 2015, we seem to be content to isolate the debate of public health reform to one venerable but troubled institution on Martindale's Road, while ignoring the real challenges to the provision of comprehensive public health care in the island. It is proven that no single investment in one institution has ever solved a society's health issues. In fact, it can actually exacerbate problems if primary health approaches are not pursued in tandem with the development of modern, accessible, and affordable health infrastructure. It is the dedicated effort of the policies and programs that put people's health first, where people are empowered to take responsibility for their own health decisions, while also having access to affordable services that do not discriminate, that makes these investments work. Spaces like Enmore, the Lazaretto, Blackman Slave Hospital, Bats Rock Cholera Burial Ground, Isolation Road, and others represent legacies of our own unhappy, contentious, and often bewildering relationship with the delivery of public health in Barbados. We have these examples of constrained, if not abbreviated, transitions in our health history. Why do we not examine them? This lecture will look at isolation as a metaphor for the development of public health policies and facilities on the Barbadian landscape since 1854. The isolation of sick bodies has been a measure that has been taken by society since at least the 6th century AD. As was demonstrated last week in Professor Welch's lecture, within the limitations of what was known about the transmission of vector-borne disease or germ theory, the history of medical isolation is justified and has been achieved through a variety of measures such as quarantine, hospitalizations, household sequester, etc. It continues to be used as a viable public health measure during epidemics for the monitoring of disease. However, like most social applications of medicine, isolation also has social and political uses. And within our health context in the region, institutionalized medicine within a hospital setting has also been used as a means to arrest public health decision-making. Historically, state prioritization of public health measures in Barbados has not always served the well-being of the population unless they have been aimed at directly improving the access to quality healthcare for all. When the state has been distracted from this mandate of primary care, not only in the provision of services and facilities, but also in public health education, community health has always suffered. Historically, these distractions have constituted the following: a preoccupation with internal and external economic forces that siphon resources from stated policy objectives. 2, a failure to provide and invest in comprehensive public health policy, not just the provision of health services, but also policy strategies and investment in education, housing, and environmental management. 3, inconsistent and even absent community delivery of health services, concessions to biased political and private agendas, and lastly, a failure to effectively consult and partner with communities and local organizations in the delivery of healthcare. This lecture seeks to trace this development through Barbados's modern public health and sanitation history, and to demonstrate that only when the real sources of threats to public health were addressed Through an integrated multi-sectoral approach by the mid-1950s, did child survival and life expectancy actually increase in the island. The mandate to improve people's living conditions through poverty alleviation, access to housing, affordable if not free medical services, and better nutrition revolutionized healthcare by the mid-20th century. Yes, the development of the QEH by the mid-1960s helped to provide a tangible symbol of the country's modern healthcare development, but it should not obscure or overshadow the valuable health work by health workers such as sanitation workers, nurses, social workers, nutritionists, midwives, laboratory technicians, physicians, environmental, health, and housing experts. The frontline health services delivered firstly by voluntary organizations and then via health centers and later polyclinics, as well as improvements in the distribution of clean water and regulation of safe sanitation, helped to reverse the centuries-long neglect of popular health care. Last time we met, I argued that emancipation precipitated an immediate, acute, and enduring health crisis when the social institution of slavery disintegrated. Barbadian planters continued to limit access to customary privileges, which the formerly enslaved received, and tightened their grip on the rigid land labor regime with scant attention to sanitation and public health. Even as gains were being made in Britain, little was done in the colony to ensure the health and well-being of the majority of the working population. In the immediate post-emancipation period, colonial health policy tended to be limited to the protection of the island's ports, trade, and military installations. When cholera swept through the island in 1854, taking the lives of over 20,000 persons, the colonial government started to take public health more seriously, but with very few tangible results that would vastly reduce the high rates of morbidity and mortality within the population. Epidemic disease continued to plague the island well into the 20th century. After 1838, the economic distress and declining profitability of the sugar industry stimulated a tide of destitution among the laboring classes, while the lack of affordable medical services and poor sanitation triggered high rates of mortality in the island for more than 100 years. Looking through the windows of several epidemics and natural disasters between 1838 and 1937, I hope I successfully argued the last time that the laissez-faire approach to healthcare, sanitation, and housing did little to protect the lives and livelihoods of Barbadians, and that the 1937 labor protest helped to articulate a vision for a livable and healthy Barbados. Indeed, the fallout from the 1937 rebellion and the subsequent Dean and Moyne Commission inquiries helped to spur a transition to self-government and social transformation, especially in the health sector. To recap, preparation for the 1854 cholera epidemic was limited to the protection of the island's economic and trading interests and did not protect the health of the population. There were some measures taken prior to the epidemic, such as the 1833 establishment of the Board of Health, but this was primarily interested in enforcing quarantine measures. And in 1851, colonial officials identified the island's vulnerability to cholera, which had swept through the ports in Jamaica and Cuba. In that year, the Public Health Act was passed, which started to address issues of sanitation, and commissioners now had greater power. In 1853, the Act was amended, but the social crisis of emancipation was so acute that little could protect Barbados's borders. In 1854, cholera swept through the island, killing 20,727 people, or 15% of the population. Subsequent epidemics and natural disasters, such as the 1898 hurricane, proved that officials did little to improve squalid living conditions and access to proper nutrition. By the early 20th century, this period was marked by a long-standing lack of development in the public health sector. The infant mortality rate was 3 times the rate in England and Wales. Public health officials acknowledged the role of infectious diseases in many of these deaths, including whooping cough, measles, and gastroenteric diseases. However, some cleverly blamed the inadequacy of mothers' feeding techniques and not the dismal sanitation in the island. nor the endemic poverty in which the working classes lived. Births were not registered, and neither were causes of deaths. There was no centralized statutory authority to oversee matters of health, and the outdated vestry system dealt with matters of poor law and sanitation on an ad hoc, unstandardized basis, governed by loose legislation in a handful of disparate acts. Sanitary inspectors were trained, and access to physicians outside of the poor law system was expensive. Even though there was an island chemist and government bacteriologist on the island by the 1910s, neither was sent periodic water samples from the island's water supply to test for contaminants. And when they were, it was not mandated that both of these units completed the testing. The first epidemic of note showed up in the 20th century, several limitations in the medical services offered in the colony. The year 1916, for example, begins in Barbados with a noted epidemic of jaundice. This was investigated at the time as a resurgence of yellow fever, but was later acknowledged to be acute leptospirosis. The lack of diagnostic capabilities made it difficult for medical professionals to discern the infectious diseases that swept through the island, particularly those with similar symptoms. By World War I, the sporadic reporting of public health matters, including epidemic disease, reveals that the colonial administration was noticeably preoccupied with the war effort on the home front than with local social and economic issues. When the US entered the conflict in 1917, the attention to local matters became more serious, since this effectively cut off a major supply of imported foodstuffs that were destined for the island. By 1918, Dr. John Hudson, who was public health inspector at the time, and is also known as the reputed father of public health in Barbados, authored an impassioned plea to the colonial government to address the declining availability of protein in the local diet. The working class no longer had access to salted meats and imported rice and cornmeal, and was relying almost entirely on local production of sweet potatoes and other provisions. More space had to be set aside for the production of protein-rich legumes such as pigeon peas and beans to help offset the malnutrition diseases that were plaguing the island, such as pellagra. Malnutrition had the expected result of weakening the immune system to fight disease. Now, if we turn to one of the endemic diseases in Barbados in the early 20th century, which was typhoid fever, we can see how malnutrition would have created space for this infection to thrive. Added to the lack of nutrition in the Barbadian diet was very poor access to clean water supplies. Throughout the 1910s and 1920s, typhoid fever became an endemic and at times epidemic scourge on the island. Spikes in typhoid fever cases usually occurred during the rainy season when flooding caused sewage, contaminated surface water to mix with groundwater sources in the island's water supply. With little running surface water, Barbados has always been a water-scarce country, which relies chiefly on the aquifers or natural springs that supply most of the island's drinking water. Although these water sources were considered safe relative to the river or lake sources found in other territories, there was an ever-present threat that dangerous bacteria or effluents could contaminate them. Rainwater could also be collected in cisterns, which was then filtered through the same porous material. However, the quality of the water obtained through this method remained dubious. Alternative beverages such as wine and Madeira, Mauby, and beer served to hydrate Barbadians. The working population, particularly in rural areas, obtained water from shallow wells and ponds that were situated either in settlements or within walking distance of villages. However, these water sources were shared with cattle and other livestock and used for bathing, washing, and drinking. All of these activities contributed to their contamination. Effluent from nearby sugar works frequently polluted shallow wells and ponds, and left stagnant, particularly at some times of the year. These sources were ideal breeding grounds for mosquitoes, the vectors for parasitic infections such as filariasis and yellow fever. Drinking water obtained from contaminated ponds also made many workers susceptible to amoebic dysentery and typhoid fever, and contaminated urban water supplies have been traced, obviously, to the cholera epidemic. Open latrines and cesspits and informal dumping were commonplace. In the absence of adequate supplies of fuel, such as firewood or coal, it is unlikely that water and food could be heated to sufficiently high temperatures to kill bacteria. And this was the water that children were ingesting bush teas and milks and feeding formulas at this time. So you can see why deaths would be very high amongst children at this time. In 1861, following the cholera epidemic, a system of standpipes was first introduced to the island, which attempted to increase the distribution of safe water supplies to communities across Barbados. By 1918, Barbados' distributed water supply was sourced from 5 locations: Plumtree Gully, Bowmanston in St. John, College Spring in St. John, Newcastle Spring, and Coles Cave. Normally fairly safe, in the rainy season, disruptions to water flow or recharge caused contaminated surface water to mix with underground water sources, resulting in disastrous effects. Most residences in rural villages did not have access to improved sanitation. Pit latrines were commonplace, but standards for raw sewage had to be enforced, with night soil being buried in a hole 3 feet deep and at a good distance away from homes. However, the rainy season eroded the land in many areas near gullies and watercourses, particularly in the East Coast and hilly terrain of the north. This forced contaminated water to come into contact with blocked gullies. On September 27, 1918, for example, during heavy rains, Plumtree Gully was blocked by excessive debris. 3 weeks later, a typhoid epidemic broke out in St. Lucie, St. Peter, and St. James, all in the water distribution zone for Plumtree Gully. The incidence of typhoid fever in Barbados was reported as 10 times as great as in England and Wales, and it was known as a filth disease. It could only be reduced by better sanitation. During the epidemic in the last quarter of 1918, most of the victims were poor Black workers under the age of 30 years and school children who were subjected to poor sanitation at overcrowded schools. The epidemic in the northern parishes was complicated by localized infection patterns. Workers, mostly masons on Spring Hall Plantation in St. Lucie, succumbed to typhoid fever after working on a building project in the plantation yard. The island professor determined excreta contaminated the drinking water from a nearby spring. Similar outbreaks were reported in St. Peter and St. James. Typhoid fever regulations at this time stipulated that victims could be treated in their homes, although isolation was recommended, but facilities were few. Some inspectors insisted that persons were removed to almshouses or even to the General Hospital in Bridgetown. However, this was not mandated, and infections spread quickly through households and communities. Disinfection techniques such as lime washing, burning bedclothes, or repetitive boiling were also haphazardly recommended and employed. The chief inspector for St. Lucie, St. Peter, and St. James reported that, as regards the sanitary organization, I cannot but condemn it. For there is not only a lack of supervision, but the staff is untrained and would be utterly at a loss to carry out any measures for the suppressions or control of epidemics. Instead, disinfection, as per regulations of the General Board of Health, I find that those deal with enteric fever have been observed only in their breach. He writes that the money paid to sanitary inspectors is simply thrown away. He called for better training of inspectors to help curb the impact of infectious disease. By 1921, typhoid fever raged in tandem with the influenza epidemic. Interestingly, in that year, the Colonial Office correspondence did not relate anything about an epidemic gripping the island. In fact, it stated that there were no notable epidemics in the island that year. The only mention of a health crisis that was reported was in the assembly debates, which stated that more money should have been voted to the General Hospital in St. Michael to cope with oversubscription. No mention of sanitation or improvements in public health were addressed, and it is as if the twin epidemic did not exist. And from some demographic research that I've been doing at the university with my colleagues Bernd Singh and Peter Shami, we have identified that there was clearly an epidemic in 1921. And it's interesting that the colonial officials did not even seek to address it in their correspondence. At this point, sanitary inspectors insisted that typhoid cases should be isolated and more training was required. Hudson announced arrangements for a course of 20 lectures in hygiene for inspectors in Bridgetown, and that a small volume of public health acts and bylaws be printed and distributed to inspectors. During this period, there was much political strife in the sanitation board with skirmishes, employee relations problems, and tenders for scavenging services not taken up by the private sector. The provision of adequate sanitation for Bridgetown was always seen as a burdensome expense to colonial officials, including sanitary commissioners. Although a waterborne drainage system was suggested by a sanitation expert seconded from British Guyana in 1921, the matter of financing such a scheme prevented any further reported discussion in the meeting with sanitary commissioners. Again, the matter came down to money. The more things stay the same. The more things change, the more they stay the same, rather. The transition to centralized public health in a community-based model, we're going to look at some health centers and, the transition to health centers and polyclinics by the 1950s. High rates of infant and child mortality persisted until at least the mid-1950s, with a spike in burials just after World War II, which is consistent with a higher birth rate in the baby boom generation. However, the epidemic typhoid and infantile diarrhea was not reported as a critical cause of death among children under 1 year. What was causing the mortality? At this time, infantile-related disease deaths constituted 1/5 of the overall causes of death in Barbados. This is in the 1950s. Bronchopneumonia was listed as a major health complaint at the General Hospital and the leading cause of death among children under the age of 1. From at least 1940 to 1955. Known as a disease of poverty, reported cases of infantile bronchopneumonia claim children either just after birth or after 3 to 6 months, which is consistent with early weaning. In fact, today, the World Health Organization recommends that the best prevention of bronchopneumonia is breastfeeding, proper nutrition, immunization against pertussis and measles, and improvements in air quality, hygiene, and housing. Again, all primary care approaches. We can see that this trend steadily decreases as time goes on and is expected with more development, and especially with the 1954 Public Health Act, when health was finally transitioned from the control of the vestry system to a centralized public health model to administer community-based health. This approach was likely due in part to the success of the few baby welfare leagues and clinics that had sprung up in Bridgetown and Christchurch, but I will leave that for Claire Millington to discuss next week. The Act facilitated the division of Barbados into health districts and prescribed locations for new health centers. Thus, Speightstown Health Center was established in 1953 and catered to the north of the island. St. Michael's Health Center later changed its name to Enmore Health Center, which was established in 1955, catered to the city of Bridgetown. Six Roads Health Center, now the St. Philip Polyclinic, was established in 1957 with equipment donated by UNICEF. Special clinics at the health centers facilitated stable access to Barbadian public health. The Six Roads Health Center, for example, provided diabetes treatment, syphilis clinics, antenatal and postnatal treatment for women. These, along with other services, were also provided at the other two health centers. Enmore Health Center had a lab, x-ray room, eye and chest clinic, whereas Speightstown Health Center had an environmental health unit. The primary health model of the health centers improved public health in Barbados almost from inception, with a steady reduction in infant mortality from 1956. However, monitoring of sexually transmitted infections and diabetics cases, which are lifestyle diseases, continue to pose some challenges in behavior change. Moreover, there was no general practice clinic at the health centers, which meant persons who could not afford the services of private physicians had to wait until the district medical officer could attend them which was once or twice a week. Unfortunately, before services were provided, means testing was applied by a social worker. Health centers failed to facilitate preventative approaches to comprehensive public health. They also prevented persons seeking general medical attention. Many of these cases ended up at the general hospital. By the 1970s, the new independent Barbados government sought to expand the primary health system through Dame Nita Barrow's vision for polyclinics. As a frontline public health trainer, she believed that more coordination was needed among the hospital, public health promotion, and school-based health education. The Warrens Polyclinic was opened in May 1976. Then in 1972, two more polyclinics were established, the Maurice Bayer Polyclinic and the Speightstown Health Center, which became a polyclinic, and the Black Rock Polyclinic, opened in November of the same year. By the end of the 1990s, there were 9 in Barbados. I think there should be a list that comes up. Yeah, I'm going. And there should be a list of all of the different polyclinics. The formation of the National Nutrition Center, expansion of immunization programs, and community health programs are responsible for the steady decline in infant and child mortality. Moreover, multi-sectoral policy shifts, which saw improvements in sanitation collection and monitoring, water distribution, and monitoring, as well as improved housing, complemented health gains in this period and constitute primary health approaches. So within 20 years, so from 1954 to about 1976, a purposeful effort to expand primary health services led to the infant mortality rate falling from 217 deaths per 1,000 live births in 1954 to an infant mortality rate in 1975 of 29, which is almost 30 deaths per 1,000 live births, which is quite striking. There's also a slide which shows the general median survival, right? So there you see over time, from 1877 to 1976, a general increase in life expectancy, or the median survival age, from 1876 being very, very low to over 70 years of age by the 1970s. Roughly every 100 years since emancipation, Barbados seeks to build a hospital to serve the tertiary or curative health needs of the populace. So it is not surprising that we find ourselves in the current debate about hospital construction. The General Hospital was established in 1841 and opened in 1844. 120 years later, the QEH opened. Each time, the justifications for hospital construction have been the same: the need for modern facilities, the expansion of services, accommodation for new technology, better cleanliness and sanitation, etc. The theme of this talk tonight was to discuss the metaphor of isolation in our health services. Whenever we have dealt with health issues in the island in isolation from the source problems of health challenges such as poverty, poor housing, poor sanitation, malnutrition, it was only through the construction of infrastructure the same health challenges persisted. But when we really started to transform the health system from the bottom up by addressing the sources of issues, significant gains were made. Yes, we need modern health facilities, but we also need new approaches and prevention so we can help those facilities become more sustainable. The discussion of health reform in the island should not start and end in one facility, but within our communities and in a multi-sectoral approach to facilitate our primary care network. Today, we find ourselves with slightly different dilemmas in a resource-challenged economic environment than we did in the 1950s. A new epidemic of chronic non-communicable diseases, a solid waste management problem with environmental degradation and vector control issues, and persistent challenges in our water distribution network in a water-scarce nation. Let us remind ourselves about the issues which have historically distracted us in health decision-making in the island. It was not until the 1950s that the state became integrally involved in the provision of modern primary health care, and it was not until the 1970s that it became more comprehensive at the point of delivery. It is arguable whether there existed enough flexibility and responsiveness in the system to deal with modern health challenges of diabetes, cardiovascular disease, hypertension, etc., especially in the arena of health promotion and education, especially at the polyclinic level. Could similar cost-effective preventive solutions through health promotion, local production of nutritious foods, access to recreational space, and environmental education for sustainable development also help to reverse these trends? As in the past, it took a new direction in primary health care delivery to effect the desired transformations in the health and wellness of Barbadians. And interestingly, it was a handful of dedicated professionals and ordinary citizens, as well as charitable groups, that led the way, especially in new frontiers for healthcare development. So I conclude with a cautionary reflection for all of us engaged in this debate. Perhaps we should take a look back before we take a step back. Thank you.